Hey everyone, and welcome back to the MediByte channel. As a healthcare professional, I am absolutely thrilled to guide you through today's explainer, where we're going to explore the actual, physical, anatomical roadblocks to pregnancy. We spend a lot of time talking about hormones and timing when it comes to fertility, but today we're zooming in on the physical structures of the female reproductive system. It all boils down to this really vital question: what exactly happens when the pathway to pregnancy is blocked? Because think about it, a successful pregnancy isn't just about an egg and a sperm simply meeting. It requires a perfectly clear, unobstructed physical highway for that fertilized egg to travel and implant safely. When physical roadblocks pop up on that natural highway, well, frustrating infertility can be the result. So here is our clinical roadmap for this explainer. We'll be covering 1. The conception pathway, 2. Fallopian tube problems, 3. Abnormalities in the pelvis, 4. Diagnosing the roadblocks, and finally, 5. Treatments and assisted reproduction. All right, let's jump right into section 1, the conception pathway. We need to look at how this journey is actually supposed to work under ideal conditions. Now, the fallopian tubes are really the stars of the show here. They're these incredibly delicate 4 to 5 inch long pathways. But here's a totally fascinating piece of anatomy for you. The fallopian tubes don't actually connect directly to the ovaries. Instead, the end of each tube flares out into this funnel shape with finger-like extensions called fimbriae. It's almost like a catcher's mitt. When an ovary releases an egg, those fimbriae have to catch it and sweep it right into the tube. Once it's inside, there are these tiny hair-like projections, we call them cilia, that work together with the muscles in the tube's wall to gently propel the egg downward toward the uterus. Actually, the fallopian tube is the usual spot where fertilization by the sperm takes place. It's a crucial meeting place and a transit highway all rolled into one. So what happens when this delicate 4 to 5 inch highway gets blocked? That brings us to section 2, fallopian tube problems. Okay, get a load of this number. Fallopian tube problems can be a factor in up to 65% of infertility cases. 65%. That is absolutely staggering, and it completely validates how common and critically important this issue really is. If that tube is blocked, sperm simply cannot get up to reach the egg, or a fertilized egg gets trapped and can't make its way down into the uterus. So what's causing the roadblock? Well, the primary culprit is scar tissue. And how does that get there? Bacterial infections are a huge cause. Bacteria from sexually transmitted infections like gonorrhea or chlamydia can travel up from the cervix and infect those tubes, leading to pelvic inflammatory disease. And here's the sneaky part. Sometimes chlamydia infects the tubes without causing any obvious symptoms at all, secretly leaving permanent damage and scar tissue in its wake. Other culprits include inflammation from a ruptured appendix, past pelvic surgeries, or a previous ectopic pregnancy, which is when a pregnancy mistakenly implants inside the tube itself. Every single one of these things triggers the body's healing response, but unfortunately that healing lays down thick scar tissue that physically glues this super narrow passageway shut. Now, let's zoom out a bit and look beyond just the tubes in section 3, abnormalities in the pelvis. Even if those fallopian tubes are wide open and completely clear, problems in the surrounding neighborhood of the pelvis or inside the uterus itself can stop a fertilized egg from successfully implanting into the uterine lining. We're talking about things like endometriosis, uterine fibroids, Asherman syndrome, and certain birth defects. Let's break down a couple of the most common ones. First up, endometriosis. This is a chronic condition where tissue that is similar to the lining of the uterus stubbornly decides to grow outside of it, maybe on the ovaries, the ligaments supporting the uterus, or, even the fallopian tubes. What's wild about this is how this misplaced tissue reacts to hormonal cycles exactly like the lining of the uterus does. It bleeds. But because this bleeding happens internally with nowhere for the blood to go, it severely irritates all the nearby tissues. Over time, that chronic, constant irritation causes these thick bands of fibrous scar tissue, known as adhesions, to form. These adhesions can literally act like superglue, sticking pelvic organs together and completely kinking or blocking the fallopian tubes. To really put the scale of this into perspective, endometriosis is found in about 30% of women dealing with infertility and up to 40% of women experiencing chronic pelvic pain. It is incredibly common, but because it usually requires surgery to definitively diagnose, it can hide out in the body as an invisible roadblock for years. Then we have Asherman syndrome. This is when those bands of scar tissue form inside the uterus itself. Now, the uterine cavity is supposed to be this nice, open, welcoming space for an embryo to implant. But if there have been previous infections or injuries from past surgeries, like a dilation and curettage or DNC, the inner walls of the uterus can scar and literally stick together. This totally blocks the implantation zone, making it a massive anatomical barrier. Uterine fibroids, which are just non-cancerous muscle tumors, can do something really similar if they grow into the uterine cavity. They change its shape and can even block the tubes from the inside out.
So, how do we find all this out? Let's put on our detective hats for Section 4, Diagnosing the Roadblocks.
To see what's going on inside the reproductive tract, doctors rely on a couple of truly brilliant imaging techniques. The first is sonohysterography. This is an incredibly safe, simple in-office procedure. A doctor injects a basic saline salt solution through the cervix to gently expand the uterus. Then, using ultrasound, they can clearly watch to see if that saline flows out freely through the fallopian tubes. Boom, no radiation, and it works great. The older, but still very common alternative is hysterosalpingography. Try saying that 3 times fast. This one uses a special radiopaque dye and X-rays to outline the interior cavity. It's fantastic for spotting structural issues, but, and here is a very crucial clinical takeaway for you, it has about a 15% false positive rate. That means in 15% of cases, the X-ray might show the tubes as blocked, maybe because the tube just temporarily spasmed, when in reality, they're perfectly fine. Now, if the imaging strongly suggests endometriosis or really heavily blocked tubes, the next step is often a laparoscopy. This is where diagnosis meets treatment. Under general anesthesia, a surgeon makes a tiny little incision right near the belly button and inserts a camera to look directly at the organs. And this really illustrates the power of modern medicine. While the surgeon is in there just looking around, they can often pass tiny instruments right through that laparoscope to cut away scar tissue, remove fibroids, or burn off endometriosis lesions right then and there. It's amazing. So once we've mapped out the blockages, we move to Section 5, Treatments and Assisted Reproduction. Our direct treatments are highly targeted. If we catch a current pelvic infection, antibiotics are your immediate first line of defense. And as we just saw, minimally invasive surgeries can clear out fibroids or pelvic scar tissue. But I do have to add a note of caution here. When it comes to surgically repairing a severely damaged fallopian tube, doctors have to be really careful. While it's definitely possible to surgically open a blocked tube, remember those delicate internal cilia hairs we talked about earlier? They are often already permanently damaged by the scarring. Because of that, even after a perfect surgical repair, the chances of a normal pregnancy remain low. And worse, the risk of a highly dangerous ectopic pregnancy, where the embryo gets stuck in that repaired tube, goes way up. And honestly, this is exactly where assisted reproductive technologies step in as absolute game changers. If the anatomical highway of the fallopian tubes is permanently damaged or blocked, in vitro fertilization, or IVF, provides a revolutionary detour. Instead of relying on the tubes to bring the egg and sperm together, doctors retrieve mature eggs directly from the ovaries, fertilize them with sperm in a laboratory, and then very carefully place the resulting embryo directly into the uterus. It completely 100% bypasses the fallopian tubes. IVF offers incredible hope to so many patients who previously would have literally had no path to pregnancy. I want to leave you with this empowering thought. Dealing with infertility can feel like being lost in a maze, but ultimately, it's rooted in human biology. By understanding your own anatomy and the physical roadblocks that can happen inside it, you are taking the essential first step in advocating for your own health. Knowledge is power. It allows you to work with your healthcare team to unlock the right medical paths, whether that turns out to be a surgical fix or a high-tech detour to build your family. Thank you so much for joining me today. I really hope this explainer brought some clarity to what is a pretty complex topic. If you found this information helpful, please take a quick second to like, share, and subscribe to the MediByte channel. We're dedicated to bringing you clear, trusted, and structured health explainers just like this one. As technology continues to rapidly advance, you've got to wonder, what incredible new medical detours are we going to discover next to make these anatomical roadblocks a thing of the past? Until next time, take care of your health and stay curious.